What is the relationship between spondylolisthesis and tight hip flexors? And not only that, we're also going to talk about the relationship between SI joint pain and tight hip flexors. So how do tight hip flexors contribute or even cause these conditions, and what can we do about it? So you've got to understand the problem in order to fix it. That's step number one. Why don't we get right into it? We're mostly talking about these muscles right here. You can see my mouse and you can see there's a big thick muscle. It's about as thick as your forearm on your body. So for me, that's a pretty big muscle. You can see where it attaches directly on the spine, specifically the lumbar spine. And we're going to be talking about how if this muscle gets chronically tight, how it's pulling on the lumbar spine and what kind of effects that can have. Here's a better view, closer up view of what we're dealing with here. So as major here is the more significant one that we're going to be dealing with. It attaches directly into the lumbar spine, and then you have the iliacus muscle that attaches to the pelvis, and then you can see it's spread out like a fan. Both of them kind of join together and they insert in the leg. When these muscles contract, they pull that leg up into like a marching type motion. It's important to know the function. There are other hip flexors that we can talk about. So this is another hip flexor muscle called the rectus femoris. You can see it's a really big muscle. And there are more hip flexors in addition to this. There's a large number of hip flexors in the body. And as a group, when we talk about the predictable pattern of muscle imbalances that tends to happen to us, these muscles are predictably tight. They predictably tighten up. And what is the purpose? Why are they tightening up? You may be able to relate this to a protective mechanism, because when the body is in danger, when the body is in pain or suffering, it tends to go into the fetal position, the curled up protective position. Flexing the hips, bringing the knees up, helps close up your body to protect those vital organs. So this may be a protection mechanism of the body. When it feels that it is in danger, it will subconsciously just send some tightness, some tension into those muscles. Here is an overview of the predictable pattern, and you see hip flexors are in the group of muscles that get tight. The entire lumbar spine is connected to this muscle group, along with the pelvis. Let's talk about what a spondy is. The most common area for a spondy is actually an L5 vertebrae slipping forward on the pelvis, on the sacrum specifically. It's not just one vertebrae that slides forward. It's actually the entire chunk of the lumbar spine that slides forward. So we have L5 here, and we have the sacrum below it right here. And the L5 is slipping forward on the sacrum. But what you notice is it's not actually just the L5 that slips forward. It's L4 that is moving forward as well. And L3 above it as well is slipping forward. So it's not just one vertebrae, it's the entire chunk of vertebrae that is moving. L5 is connected to the entire chunk of the lumbar spine, and the entire thing slides forward in a spondy. That is largely evidence to me that because the hip flexors are connecting the entire lumbar spine together, they are pulling that lumbar spine forward, and it's actually all blended together. And the muscle is really connecting all of the lumbar spine into one unit, essentially. And so if this gets tight, then it's going to pull that whole unit forward, which is sitting on the sacrum or the pelvis. That is what can lead to a spondy. There's nothing in the back keeping it from staying in place. There's not enough force pulling from the other side. And that force would come from muscle groups like the glutes and any other muscles that can help posteriorly rotate the spine. Largely the glutes, the abdominals also help to protect or block that forward movement and posteriorly rotate the pelvis. And I have a spondy in my spine, or I've had one in the past, and it appears actually that I've corrected it to some degree, and actually maybe even overcorrected it with the last imaging showing that it's actually now a retrolisthesis. And so this vertebrae is now a little slid back on the sacrum. I was able to correct a spondy, and now I have to actually be careful on how much I'm correcting it. If you don't already know, sitting is one of the most contributing factors to tight hip flexors. And you can see that this hip flexor muscle is in a shortened position. Okay, this is actually the TFL. This is a hip flexor muscle that I didn't even mention before because there are so many of them, and this one is a little bit less significant than the other one. This one is the rectus femoris, also in a shortened position. You are approximating the two attachments of the muscle, making it shorter. And so we're spending a lot of our day in this position, shortening those muscles. You're probably doing it right now, just like me. And it's also semi-active. I'm moving, I'm using the muscles, so I'm training them in that shortened position. When we spend so many hours training a muscle in a specific position, it will become trained to stay in that position. And then we get up. Now we're in the standing position, and these muscles have been trained to be shortened. Guess what they're going to do? They're going to maintain that shortened position and be pulling. There's going to be more tension on the two attachments. Well, the legs are straight. You're standing on them. So what's going to give? The lumbar spine is going to give. It's going to get pulled forward a little bit. And if you repeat that over and over for 10 years, something's going to break down eventually. And one of the least supported areas of the body is the lumbar spine. We don't have the bony support that the rib cage provides in the thoracic spine or the pelvis provides down below it. So you have this gap of no bony support, and that's the area that tends to give. Sitting contributes to tight hip flexors. Tight hip flexors contribute to things like spondylolisthesis or you could address this exact same thing to a SI joint problem, because guess what? If we really break this down, we can see that the iliacus hip flexor muscle is pulling forward on the ilium, on the sides of the pelvis, but it does not attach to the sacrum. So it's creating torque, pulling forward on part of the pelvis, but not the sacrum, which is another part of the pelvis. And the joint between these two bones is getting what we call torque, that rotational force on it. And day after day of repetition of this type of torque will eventually break down the joint between those two forces. It's not only spondy, it's not only SI joint problems, but we can also relate tight hip flexors to things like stenosis, causing that excessive backward bending or extension in the lumbar spine, because our bodies will tend to live in a state of extension because that spine is getting pulled forward, which will create that extension or backward bending position. We're not actually trying to backward bend, we're just trying to stand up straight, but those tight hip flexors are not lengthened enough to allow for the spine to fully straighten. This is the relationship between biomechanics and lifestyle, something like sitting. So what do we do? I mean, the next question naturally is, what do we do? How do we address this? And really that's what the recipe I've laid out in the program is for the person who falls into the category of the 80%, who falls into an anterior pelvic tilt, who tends to have tight hip flexors. And we can train the muscles to lengthen in an active type way with exercises such as the bridge. Walking is an excellent thing to do. If walking doesn't hurt you, then you should be doing it all the time, not just once a day, but 5 times a day. And that is an excellent muscular balance activity to be doing to not only lengthen the hip flexors, but address so many other of the muscular imbalances that we have related to sitting. These are the visuals. This is just the anatomy lesson for you guys today to better understand the problem, the relationship between this, and the result that leads to this. And for a lot of people, sometimes leads to this. Because when we have a problem with an instability in a joint, the medical system's solution is to reinforce that joint with hardware. This is what a lot of people end up having to go through. This is a 3-level fusion. Here is a 2-level fusion. Ideally, we'd want to avoid this. It's not always avoidable, but if we can create the stability that the surgeon is seeking through hardware, if we can create that through muscle tension and creating a sense of balance around the spine with our muscles, it is possible to avoid something like a fusion. You can see when the tension is, the torso is feeling supported by the muscles around the cylinder, that it actually allows the hip flexor muscle to go on slack. But if the body's not being supported by the muscles around 360 degrees around the cylinder, the body has to compensate and try to create support for the spine with other muscles that aren't necessarily designed to support the spine. They're more designed to flex the hip and create movement and walk and do things like that. It can put tension into those muscles to try and protect. And in that process, it may actually be causing another problem. There are exercises that I would recommend avoiding with a spondy, and I've actually put out an entire live stream and YouTube video on that topic. So I would recommend watching that. And if you learn the exercises to avoid, it will give you insight in the ones that you can do. But really what you want to do is anything that can help activate your abdominals and your glutes, and also simultaneously be allowing you to open up your hips or lengthen your hip flexors. And so the perfect exercise to do that would be the bridge, if you do it in the right way. And you must be doing the bridge in a healthy, core connected way. And if you're in the program, that's what we teach in week 1 in the free trial week. So that's what I would recommend to start with. And then you can apply that core engagement and that connection to all the other exercises that you do. And that is how I was able to reverse my spondy. It was so effective that I actually have a little bit of the opposite problem, where I have now a retrolisthesis. It is possible to affect a spondy with posture, movement retraining, and exercise. I hope you got some benefit from just seeing the visuals of the hip flexors and how they attach to the spine and how they can pull the spine forward. If you enjoyed that at all, feel free to support the stream, hit the like button. Until next week, get down on the floor and connect to your core. All right, take care, everyone.